Good afternoon, everyone. My name is Jan Sorensen. I'm the director of the RCSI Healthcare Outcome Research Center and professor of health economics. Again, today, it's my pleasure to welcome you all to this webinar in our Future of Value-Based Healthcare in Ireland webinar series. Today's seminar is called Patient-Centricity in Irish Healthcare, How to Make It Work. Patient-centricity means designing a service, treatment, clinical trials, or other health solutions that are centered around the patients. Creating a patient-centric solution involves getting feedback from real patients and their families, and making decisions that are based on their needs and perspective. It is widely recognized that patients in Ireland have a part to play in improving the quality of services that they receive in the design and delivery of the service. Meaningful consultation with patients can help service providers to understand the quality of care that patient receives and how patients value the treatment they receive. Today's webinar will discuss how to ensure that value-based healthcare initiatives are patient-centered. Unfortunately, one of our speakers had to send her apologies. We are very grateful to Anne Dorlo from the 22Q11 Ireland support group for accepting the invite and stepping with very short notice. We're very happy to welcome our four speakers and thank them for their willingness to share their knowledge and experience with us. We're also grateful to the former HSE General Manager, Tony O'Brien, for again today take the role as a moderator. I would like to acknowledge the continued support for planning this webinar series from Mark Cavanan and David Dunn from Janssen Pharmaceuticals and Bridget Cunningham from Novartis. I would also like to thank the two companies for supporting this webinar series. Finally, I would like to thank Sandra Flood and her colleagues from Wilson Hartnell, who had helped organize the program and secured the speakers and providing the technical solution for the webinar. Before I hand over to Tony, I just want to ask all the participants for a favor. This is the last session in our webinar series, and we would like to do a formal evaluation to consider if there's a need for future seminars in the future. In the coming days, we'll send you a brief evaluation form, and I will ask you to complete and return that. Because of the format of the webinar, give us very little impression of how the webinars are received. It's important for us to hear from you how we might make similar arrangement in the future. I would therefore encourage you to complete the form and send it back to us. Thank you very much in advance. It now gives me great pleasure to hand over to our moderator, Tony O'Brien. Tony, the floor is yours. Thank you very much.
Thank you very much, Jan, and thank you and welcome to everyone who's joining the webinar today. The format is a very simple one. We have four excellent speakers who will each present for 15 minutes. Following that, we will have a Q&A session, and you can at any stage enter your question in the Q&A function at the bottom of the screen. So it's now my pleasure to introduce our first speaker. Professor Frances Horgan is a physiotherapist and Associate Professor of Physiotherapy at the RCSI University of Health Sciences. Her research interests are older person and stroke rehabilitation, health service research, and interprofessional education. You're very welcome, Frances. The floor is yours.
Great. Thank you very much, Tony. Slides up here now for everybody. Good morning, everybody, and thank you very much to the organizers for the invitation. And I'm delighted to be with you all today to discuss some experiences that we have had in our research group in RCSI in the context of patient centricity, making it work in the context of research and sharing our perspectives with you. So if we look at the definition of patient centricity, we can see that it's very much about putting the patient first and thinking about open engagement, and obviously ensuring that that translates into a quality experience for the person and for their family as well. Now, the trends in patient centricity in research are certainly increasing, and we can see just from this graph that there's been a significant six-fold increase over the last 6 years in the focus on patient centricity and public and patient involvement. So if we look at the definition of public and patient involvement, this is the definition taken from the UK. And public and patient involvement in research is defined as carrying out research with and by members of the public, rather than doing the research to them, about them, or for them. So it's very much about engagement. And I suppose there's a very broad description of public. We think about patients who've experienced the service, or maybe potential patients, their carers, family members. So this has been a huge change in our research and our research focus over the last number of years. And there's been significant investment from one of the national funders, the Health Research Board, in convening a group of universities to create a collaboration which is called PPI Ignite. And RCSI is part of PPI Ignite, and the focus of PPI Ignite is promoting excellence and innovation in public and patient involvement, and supporting us as researchers in our different universities to conduct meaningful collaboration and to support us, because it is very much a learning process to embed PPI and patient centricity in our research journey from the very beginning when we're developing our research questions, through to the conduct and the implementation of our research, and right through to the very end when we're trying to summarize the messages and what the implications are for our research. And I suppose thinking about research in the context of today's research being tomorrow's healthcare. So that sort of partnership approach, really a triangulation of looking at the evidence, improving the quality of the evidence, thinking about that evidence in the context of improving services for patients and the public, but also reflecting on their experience as well and what we can learn from their experiences. We can see that public and patient involvement is becoming much more apparent now in the research, and indeed the publications that are coming through, embedding public and patient involvement, and thinking about the learning process at the beginning of projects, evaluating it in doctoral training programs where students are coming to do their PhDs and a significant research program, and colleagues who are successful in these awards are reflecting on PPI, engaging with PPI, and learning from PPI. And of course, we can also look at how much research has been conducted in PPI in terms of doing realist reviews and looking at the processes as well. Now, one area I wanted to explore with you in relation to our experience of patient centricity and PPI is in relation to stroke care. We know that stroke is a significant cause of disease and disability in Ireland, internationally, and in Europe. There's going to be a significant increase in the number of stroke events, and this is borne out from the work of the Burden of Stroke Report and the Stroke Alliance for Europe, SAFE. Stroke has a significant impact both in terms of cost of providing health services, and this is set to increase, but more importantly on the person who has had the stroke and those who support that individual and living with the effects of stroke and life after stroke. So this is a very important research area, very important clinical area. There's been a huge amount of research conducted in stroke, and I suppose that research is embedded in our practice and we can see that, but we can learn a lot more from the patient experience. This slide summarizes the stroke register report from NOCA, the Irish National Audit of Stroke. There's a register in all the hospitals. The clinical nurse specialist colleagues and therapists are inputting data. This allows us to look at how hospitals are performing. This is obviously very important for quality services. The KPIs are matched and to clinical guidelines that have been developed, so we can look at our performance in relation to the provision of stroke care, how many patients are coming into the hospital, what treatment are they receiving, how long do they spend in hospital, how soon do they get into the stroke unit, how long are they treated in the stroke unit, what types of multidisciplinary assessments do they have in the stroke unit. So this would not be possible without all the work of colleagues who input this very important information to allow us to evaluate how the services are performing. And indeed, in terms of looking to the future for investment and policy and practice in health services, there's also been significant work in collaboration with advocacy agencies and clinical partners in developing stroke policy and stroke strategy for the future years. And this is very much focusing on the stroke journey, thinking about the very beginning when the stroke event happens and somebody needs to get to hospital, thinking about that care in the hospital, thinking about the discharge phase and living well after stroke and preventing a second stroke, thinking about rehabilitation and accessing rehabilitation, which is very important for restoration of movement and recovery and getting back to work and all those activities that are important to the individual. And of course, supporting all the clinicians who deliver the care as well. So there's been a huge amount of work in terms of bringing evidence into practice, measuring what we're doing, planning for the future, because at the I suppose that the background of all of this is an individual who's had a stroke, and we can see here from this schematic that the journey is a very complex journey. So we can see on the bottom line here that journey from the stroke event, coming to the hospital, the HAZU, the hyperacute stroke unit, the acute stroke unit, starting rehabilitation, continuing rehabilitation, and of course rehabilitation can continue for quite a significant period of time as well. In the top left corner, we can see all the different healthcare professionals who are involved in delivering care. To the right-hand side of the screen, we can see that sort of the period around discharge planning, where the journey of rehabilitation continues in the community. So this is very important, just at the background of thinking about research, thinking about stroke, and having engagement with those who have had a stroke. Because here in this slide, the stroke journey is also mapped at the bottom. So the detection, the early warning signs, the presentation to the emergency department, through to the diagnosis, the rehabilitation, going to ESD, which is early supported discharge, and there's the significant investment in early supported discharge. And where all these circles intersect, we can see that there's a transition point. So we know that many patients are coming into Irish hospitals every year, about 4,300. A significant proportion are having thrombolytic therapy, clot busting therapy to facilitate their recovery and to minimize the damage to the brain cells. But there are significant transition points. And when we look at these transition points as part of priority setting exercises or consultation with patients or hearing their views, they still report challenges. So despite the investment, despite the progress, there are still some areas that need further attention. And there have been a number of PPI and stroke research priority setting exercises, which is very important to do because this helps us to have an understanding of what the priorities are for the person who's had a stroke. And they can often relate to cognition after stroke, communication difficulty after stroke, vision, their upper limb recovery, mobility and fatigue, and indeed life after stroke. So that is one aspect. Another aspect is that listening to patients, they tell us that they do feel a sense of abandonment. So we do need to probe this a little bit further to understand what are the contributory factors here. So back in 2019, a group of researchers in RCSI came together. We were looking at a funding call, which is called the HRB Collaborative Doctoral Award, which funds doctoral training programs to train future health researchers to be leaders in stroke research. So we convened a roundtable group of 20 stroke survivors. We put a call out through the Irish Heart Foundation, the National Stroke Advocacy Organisation. We put an open call out. About 20 people responded to our call from all over Ireland. We had stroke survivors, their family members, stroke support group coordinators. We came together in RCSI to discuss everybody's journey after stroke and their experience. And that roundtable discussion was facilitated by my colleague Olive Lennon in UCD and by Jan, who's on the webinar today. And we listened very, very carefully to what everybody said. And we can see some of the messages are represented in the image here. Many of the patients described, many of those who had the stroke described how they'd had thrombolysis and they were moving between hospitals and it was an uncertain time for them. Many described how when they were discharged from hospital, they felt like they were falling off a cliff. For some, they were referred to early supported discharge services for which they were very grateful to continue their rehabilitation. But they still did experience some challenges when they came to the end of that period of rehabilitation. And for many, they were living with many comorbidities and stress in their lives and maybe perhaps some unhealthy lifestyles prior to their stroke and wanted to get back on track and think about healthy diets, more activity and leading healthy lifestyles and that whole area of secondary prevention. So this consultation allowed us to have a dialogue, a meaningful dialogue, to sit down together to think about what were the priorities for the research questions. And as a result, then we sat down to write the application for the funding. And thankfully, we were successful. And our Collaborative Doctoral Award, which is a 5-year funded program, is called IPASTER, Improving Pathways for Acute Stroke and Rehabilitation. So we started our program together with our PPI partners in 2020. And we have 4 research projects in this award. And you can see that we have 4 healthcare professionals. We have a doctor, a physiotherapist, a nurse, and a health economist who are leading these 4 projects. And the 4 projects very much reflect the conversation that we had and the challenges that we heard that mapped to the stroke journey and that pathway of care. So project 1 is very much about the early stage and accessing care in hospitals. The second project is very much about the early supported discharge or the transition experiences and improving those transitions to support individuals. And then the third project is about staying well after stroke. And our final project is looking at new interventions that will emerge from these projects and how we will ensure that they are cost effectiveness and value for money, and all the while embedding PPI in this process, in this 5-year journey together. So our public and patient champions are embedded in all the projects. Each of the scholars, PhD scholars, works with the PPI champion. We have our PPI advisory group of 20 people, and we're discussing all of the progress as we start this journey together, and indeed on our steering group as well. So there's been a lot of learning from us, for us all, as we co-develop the projects, the methodologies, the ethics documentation, the questions we would like to ask, the questions we would like to ask in interviews. And some of our PPI partners are going to be co-researchers on the projects as well. So they indeed will facilitate further consultation with those who've had a stroke in terms of getting their views on how we can co-design improvements to facilitate these transitions of care. So at the end of this journey, we will have a group of postdoctoral researchers who will go on to be leaders in leading future research in stroke care. We will harness our meaningful PPI as we go along this journey together, thinking about the training, thinking about how we're learning from each other, the different skills that we have to share, sharing our expertise, and having very meaningful conversations together. And I suppose this has been a learning process, and we're now at the point where we're midway through our collaborative doctoral award, and we're reflecting on the progress that we have made, but we're also reflecting on the learning of embedding PPI and ensuring that it's meaningful PPI and patient centricity that is embedded in all the projects and in all the activities that we do. Because researchers can do different types of studies, and we can have different types of PPI involvement as co-researchers or advisory panels. The key message is that it is meaningful, and it's very much about listening and having the conversation. And of course, we're all learning together about PPI, and we've been very fortunate that we have resources within our award to support our PPI activities as well. And that's extremely important because many of our PPI partners have now returned to work after their strokes, which is fantastic. And we need to be very respectful of when we convene meetings and how long those meetings are. So it's been very much a learning process for embedding patient centricity in our iPaster projects. Of course, the other thing that's happening now is that as we engage with our PPI group, we're also sowing the seeds for new research projects. And we can see that the conversation is very much centering around other emerging areas that need attention. And one of these that struck me recently was aging with stroke. So many of our PPI partners have had their strokes maybe 20 years ago, and now we can see that there's maybe some change with aging and their joints and their mobility. So it's causing us to reflect on new research questions, what the research is telling us, how we can apply that research, but how we can listen to people's experience of their journey and really start to understand that a little bit more and co-design research together and co-design solutions together, because it's about us working in partnership and listening to each other and finding the solutions to these issues and to these challenges. And it might be that it's a very simple solution, like maybe a review at a clinic or some signposting of information that can really make a big difference, because this slide shows us the trajectory of recovery after stroke, and it's very different for everybody. So of course, that's a challenge in terms of designing services as well, and the services have to be cost effective, and we have to add value to the services as well, because patients continue their recovery. It's very individualized, and it can continue long into the future. So these are lessons from science that we can apply as we reflect on the solutions for the different questions that are coming through in our engagement with PPI. So to conclude, patients in Ireland have a key role to play in improving the quality of the health service and thinking about the principles of patient centricity at the centre of this, how we can maybe think about it in a triangulated approach that we're all working in partnership together, policy and practice, developing the services, evaluating the services, keeping the patient and the family at the centre of all of this. It's very important that we listen very carefully, that it's meaningful consultation, that it's not a one-sided approach, and it's a very rewarding conversation that we have had with our stroke PPI partners. So really, it's a very exciting time in terms of the evidence base that is changing, and I suppose innovation in our health services as well. So thank you very much for listening, and I think it's very exciting for the future as we co-design solutions together. Our service patient-centric. Thank you. Back to you, Tony.
Thank you very much, Frances, for a very clear and insightful presentation. Frances will be joining the panel at the end, so if you have questions, please do use the Q&A function. I'm now pleased to introduce our next speaker, who's David Galvin. David returned to Ireland in 2011 after working in both Memorial Sloan Kettering in New York and in Essex to take up an NCC post in Dublin at the Mater and St Vincent's University Hospitals to support early prostate cancer diagnosis in the rapid access clinics. He was awarded a €1.7 million grant by the Irish Cancer Society and Movember to establish the Irish Prostate Cancer Outcomes Research Programme. David.
Thank you so much, Tony. I hope you can hear and see me there. Listen, thank you very much for this fantastic opportunity. I'm very excited to be able to tell you about the Epcor project, which has really been since its birth about 8 years ago. Myself and the team have been working hard on to develop it, and it's gathering increasing momentum, which is very rewarding for all of us involved. So I just wanted to start off with apologies for a few text-heavy slides here, but just wanted to introduce a few sort of key issues around the issue or the concept of clinical quality registries and patient-reported outcomes. So I suppose for clinicians and so on, similar to looking after a patient, the decisions that we make regarding our healthcare services and our patients rely really on the evidence that we have. So high quality clinical evidence is clearly very important when looking after patients, but equally when designing services for our patients. As Tony had said, I was fortunate enough to spend some time in Memorial Sloan Kettering, where you can see where high quality clinical evidence collected over long periods of time allows for massive service improvements in hospitals like that gain at the high status that it has around the world. And they concentrate now more on the collection of patient-reported outcomes as well. We are all very conscious that our health budget is a finite resource, and therefore the decisions that we make using the finances of our health resources need to be based on high quality evidence and driven by improving patient clinical outcomes and getting value for money. Patient-reported outcomes are a reliable method of measuring the quality of care provided to the end user satisfaction, and they've been a very important aspect to the Epcor study. Obviously, achieving value in our health service should see funding support services where high quality clinical outcomes and patient-reported outcomes are captured. It seems nonsensical to be continuing to support services where there are poor clinical outcomes or poor patient outcomes recorded. So I'm going to focus on prostate cancer, and I realize that there are a lot of people from other areas of medicine maybe listening in, but prostate cancer specifically obviously is of a key interest to myself and my colleagues in urology. It is the commonest solid male cancer in Ireland, and as a result of its early detection in the vast majority of patients, there are vast numbers of prostate cancer, if you want to call them survivors, or men who have gone through prostate cancer treatment in Ireland. And in fact, prostate cancer survivors are the commonest commonest cancer survivor in Ireland at this time. The side effects from prostate cancer can be very significant for men, particularly infertility, urinary leakage, and sexual dysfunction would be the commonest. But the psychological consequences of those side effects can be very severe. Many men, in fact, up to 60%, are estimated to suffer significant anxiety, clinical depression, which can lead to relationship difficulties, marriage breakdown, financial and employment issues, and even patients of mine have committed suicide in relation to their diagnosis. Unfortunately, in Ireland, there is no support structure in place, there is no funding in place, there are no psychological services or no survivorship services currently in place for these men. Epcor intends to assess the unmet needs of men with prostate cancer while providing the evidence base to improve cancer services. So Epcor has collected an extended clinical data set between 2016 and early 2020 in partnership with the National Cancer Registry in Cork, collecting diagnostic and therapeutic data on men newly diagnosed with prostate cancer. The patient-reported outcomes were also completed by a subset of patients, and a 20-page, very detailed PROMs report was completed by our patients, including detailed demographic data, supportive care needs survey, and validated questionnaires focusing on urinary, sexual, and bowel function, health and quality of life survey, and activities of daily living. We've also engaged patients since the really inception of the Epcor study. We've had patient engagement on our steering committee since 2014. And in 2016, as the study went live, we established a public patient engagement group, which advised our study throughout its course. We too have involved patients at a more senior level. And Martin Sweeney, one of our patient ambassadors or champions, has led on a HRB grant called Supportive Unmet Care Needs of Men with Prostate Cancer. And we also have a patient who is a co-investigator for the next phase of our Epcor study. So we've always engaged with patients and they've influenced the study right along its course. I'm going to give it just some of our clinical data and also some of our recently developed PROMs data as well throughout the talk. In total, we have registered 6,816 men, approximately 85 to 90% of men diagnosed with prostate cancer between 2016 and 2020 in Ireland. We engaged with 69 urologists, radiotherapists, and oncologists across Ireland, and we recruited patients in 16 hospitals across the country, 8 public and 8 private. Also, a subset of patients, 873, completed their PROMs. So we collected a variety of clinical information and non-clinical information that would be of interest to patients, particularly, for example, around access to care. So here you can see the 6,800 men, the average distance that they have to travel to hospital is very different. Everything from 500 meters right out to over 300 kilometers. And this obviously can impact on patients' access to care, diagnostic pathways, and the treatments that they ultimately select. We also looked at how they presented. You may be aware, we have a rapid access prostate clinic where patients should be seen within 20 working days when referred by their GP for suspicion of prostate cancer. And these have proved to be vastly successful. Despite approximately 50% of patients having private healthcare in Ireland, you can see here that between 70 to 75% of patients actually utilize the public healthcare system presenting through the rapid access clinics. As patients age over 70, they don't have access to the clinic, so you'll see there's a slight drop-off in patients accessing that service. We also looked for the time delays in the diagnosis and patients being informed of their prostate cancer diagnosis. Here on this graph, you'll see the different pathways for private patients, the rapid access patients, and public patients over the age of 70, from the time of their PSA prostate cancer blood test to their prostate biopsy, and ultimately to being informed of their diagnosis. The average waiting time to be informed of their diagnosis is approximately 100 days, but you can see that through the private healthcare system, there's definitely a more efficient diagnostic pathway. Prostate cancer used to be considered a diagnosis of old age. And what you can see here in this infographic is that 2/3 of men in Ireland are actually under the age of 70. And only 1 in 20 men are over the age of 80, with the average age of diagnosis being approximately 65. So we just say the key points here in relation to access is that approximately 20% of patients are aged between 40 and 50 at the time of diagnosis, and 2/3 are under the age of 70. So this, as a disease, should no longer be considered a diagnosis of old age. And many of the patients working may be the breadwinners within their families, employed, and obviously the consequences of their diagnosis to them may be very significant. We also are able to assess whether or not the patients presented with any symptoms. And you can see here that about 4 out of 5 patients were essentially had no symptoms in relation to their prostate cancer. And all of these patients were diagnosed based on their PSA blood test. This has significant repercussions because a lot of the advice given to patients is to present to their GPs once they develop symptoms. And in our experience, this is too late. 4 out of 5 patients in Ireland today currently have no symptoms and are being diagnosed based on their PSA test. So we would call for certainly for widespread PSA testing. If you break down those patients by age, you can see that patients under the age of 65 are much more likely to be asymptomatic. And as patients age, they are less likely to be what we call screen detected. So they're more likely to have symptoms in relation to their cancer, which is what the advice would currently lead us to believe that patients who age should not be detected by screen detected methods. This is a measurement of the 6,800 patients and their PSA or prostate blood test levels and what their average blood test reading was at the time of diagnosis. I'm very glad to see that most patients had a very low PSA blood test, with the average age or the average PSA level being 7.2, the normal for most men being less than 4. So most patients had a low abnormal blood test. And when we break this down then by the route of access, it's very gladdening to see that whether a patient has private healthcare insurance or is going through our public service, that they essentially are presenting with the similar PSA values. Essentially, a PSA is used as a surrogate marker for the burden of disease. So you can assume that all patients are presenting with the same levels of disease, regardless of their ability to pay for their healthcare. So I think this is a massive improvement in our healthcare, as there was a publication approximately 30 years ago from the Cancer Registry, which suggested that a patient's ability to pay for their healthcare in prostate cancer was the fundamental difference between their outcomes. We also captured all the pathology on all our patients diagnosed with prostate cancer. We use something called the ISUP or Gleason grading system in prostate cancer. And here you can see the different aggressiveness of the cancers that were diagnosed. You can see in the under 65 age group, the vast majority of patients' prostate cancers are actually less aggressive, whereas patients that age tend to be diagnosed with more aggressive cancers. And this is largely down to physician discretion, trying to avoid the overdiagnosis in men as we age. Using a number of variables, we're able to assign a patient a CAPRA score, which is an international validated system for assessing and risk stratifying patients with prostate cancer. Using that information, we're able to risk stratify every patient with prostate cancer in Ireland. And you can see that the CAPRA score for all our patients is registered here, the vast majority of patients having either low to intermediate grade disease. As a result, you would expect patients in the low to intermediate grade section to need less treatment and therefore take less resources up within our healthcare system, whereas those patients with higher risk disease are likely to need multimodality therapy or need longer treatment courses. And therefore, we'd be able to use this information to track patients and make sure that they are not overtreated or don't require additional resources. For example, when we look at staging scans that are used to stage someone's cancer at diagnosis, we look at bone scan and CTs. And you can see here that doctors are ordering more bone scans as somebody's risk score goes up, which is entirely appropriate. And we have guidelines as well that allow us to assess when and where a patient should have bone scans. You'd have to question as to why patients with low risk disease were getting bone scans. And I know of a incentive or a project in Michigan called the Music Project, which was funded by Movember, where they used data like this to reduce the number of bone scans and CT scans in patients and make considerable cost savings within their healthcare system. And here's the similar graph for the CT scans as somebody's risk stratification increased. Similarly, MRI scanning and getting an MRI scan before your biopsy is a difficult situation in Ireland at the moment, largely due to access to MRI scanning. we know that patients who are able to get an MRI scan before their prostate biopsy can have improved accuracy and higher diagnostic rates ultimately for their biopsies. Prostate cancer guidelines in the NCCP to be released later on today are calling for improvements in pre-biopsy MRI access. This graph just shows that on the green line is the date of the patient's biopsy, and approximately 1/3 of patients at the time of this research were able to get an MRI scan before their biopsy. And this research was able to show that if patients had private health care at the time of this research, private patients were 3 times more likely to access an MRI scan before their biopsy than afterwards. So we've made certainly improvements in access to MRI imaging across Ireland in the recent years, and I think this data has changed considerably. Closing in then on our PROMs research, you can
hear that these are the patients who completed our patient-reported outcomes. So you can see here that patients have offered a lot of information regarding their demographics, their education levels, and through further research, we'll be able to correlate this data with their outcomes. For example, using the patient-reported outcomes, we're able to ask patients as to how they are feeling overall, and this is an assessment of their psychological outcomes. We're also able to break that down into patients who ultimately underwent surgery versus patients who underwent radiotherapy. And I'm glad to see that we can see that there is very little difference in patients' health today, which is approximately measured 2 years after their treatment, as to whether or not they had surgery or radiotherapy. This sort of data is greatly reassuring to patients who are concerned about making the choice between surgery and radiotherapy at the time of their diagnosis. We also focused in on things that are important to patients, such as their ultimate urinary function after treatment, or their sexual function and bowel function. Here you can see on this graph as to the sort of problems patients faced approximately 2 years after treatment in relation to their urinary function. You can see there that some patients certainly were continuing to encounter big, moderate problems in their urinary function. In this graph here, you can see that as time goes by, there is a gradual improvement in urinary function for patients overall. And when we compare the radiotherapy versus the surgical groups as to their urinary outcomes, you can see there that there are some small differences, but overall, we don't seem to feel there is any clinically significant differences in the outcomes between these two groups. When we look at bowel function equally, we can see that there are a very small number of patients who have significant bowel problems following their prostate cancer treatment. And this graph shows that as time goes on from the point of their treatment, that there really isn't any great change in terms of their bowel functioning, and most of the bowel function seems to be through the earlier first 1 to 2 years. And this is reassuring for patients who may be encountering problems, that their problems are gradually going to improve. You can see there that the patients who undergo radiotherapy are more likely to encounter bowel problems, which is what we all recognize, and patients are advised accordingly. Just looking then at sexual function. So you can see here, quite different to the other two graphs, that sexual function after treatment for prostate cancer is a major problem for patients after treatment. And many patients continue to have big problems. This graph just shows that despite time, there is little improvement in patients' sexual function over time, and that patients appear to be getting increasingly frustrated and have increasing difficulties as time goes on following their treatment. This is obviously very important because as we build survivorship programs and design follow-up treatments for our patients, this is something of a major concern to patients and should be a real center of our focus of our survivorship programs as these are being developed at the moment. And you can see here that both patients undergoing radiotherapy and surgery seem to experience very similar problems. Now, this and other problems are going to be further researched within our evolving research program. We want to very much welcome Dr. Noah Gordon, who has just been appointed in UCD as the Janssen Movember Newman Fellowship in Prostate Cancer Outcomes Research. We believe this is the first type of fellowship program in these islands, and she's going to be, and she's just taken up position in UCD and will be working on this area over the next 2 years. The project continues to gather pace, and we are in further discussions with other agencies and industry about future funding. And we're also planning an Epcor phase 2 with future Movember funding coming on board over the next 4 years. That future funding is going to help continue to support our clinical data collection, our PROMs data collection, but we're also going to develop a biological samples collection and evolve with a biobank, which will help with laboratory-based research also. And this will be through St. Vincent's, Mater and Galway Clinic, as well as St. Luke's Radiation, where we will employ research nurses to liaise with patients in collecting digital PROMs from these patients, as well as biological samples. Just want to thank my research team and all those who've worked tirelessly over the 8 years and stuck with the program: Bill Watson, Frank Sullivan, Sharon Glynn, Linda Sharp and Ray McDermott, and our office staff, Anya Murphy and the project manager, and Cara Dooley, our statistician. Thank you very much.
Thank you very much, David, for a very data-rich presentation, and I'm sure that that will have stimulated a number of questions. And just to remind everyone that the Q&A function is available for the panel. We're just going to take our remaining 2 speakers in a slightly different order for reasons which I'll explain later. And I'm very pleased, therefore, to introduce now as our 3rd speaker, Derek Mitchell. Derek is the Chief Executive of EPOSI. He has a background in research, strategy and advocacy, spanning over 12 years experience in leadership roles in research and multi-stakeholder engagement in Ireland and at EU level. His CV is too vast really to summarize, but it's worth mentioning that he's an elected board member of the European Patients Academy Foundation and is chairperson of the European Patient Representative Roundtable. Derek, the floor is yours.
Thank you, Tony, and great to be involved in today's webinar, and great to be going in order. And I can't wait to hear from Anne after my presentation. I always probably prefer the patient or the parent voice to be going first, but I'm happy to deliver EPOSI's perspective on this topic. And really, I think it's appropriate that EPOSI offer a perspective on this topic, because it's really the reason why we were set up over 15 years ago in Ireland by patient groups to act as that neutral platform that creates spaces whereby patient voices can be heard and hopefully then embedded more in healthcare, but also in the entire health system. So that's across service delivery, policy, research, and indeed, as we've heard already today, some of the really innovative approaches that are being taken. And really, if anybody is unfamiliar with our work in this area, it really boils down to 3 kind of areas, and it's about education, it's about advocacy, and it's about information. So we do lots of different types of activities that are all geared towards one ultimate goal, and that's to encourage greater inclusion of patient voices and indeed increasingly the public voices in the decision making that's made on behalf of patients, but very often without their involvement. So we're over the 15 years of our existence, we've probably grown to the largest network of both patient groups and individual advocates in the country. So again, we're speaking today from our experience of both getting involved ourselves as an organization, but also involving many of our members. And the areas of priority that EPOSI focuses on, well, patient and public involvement, if I can use that term rather than the patient-centricity term, is very much a key pillar of our organization and a priority area, and it embeds everything it encompasses everything we do. We do focus a good bit on access to innovation and really looking at the challenges around accessing new and improved treatments and therapies and diagnostics and digital health in particular. But the patient and public involvement is really where I think the focus of today's aspects we're going to focus on. And I think from our experience of engaging with the likes of the HSE and the Department of Health and a number of state agencies in I guess the public side of the healthcare system. What I've highlighted here is the kind of the five, what we believe are the five main aspects whereby patient centricity can become, I think, more embedded and less of a mantra. Because the reality is, I think that at the national level, particularly at the level that IPOSI operates, there is a lack of connectivity within the different types of innovation and innovative approaches that are being taken. And there's probably a need for greater leadership in this area. So when I talk about patient centricity, it's with these five key elements. So it's the individual experience of healthcare. And when I refer to that, it's more than just, I think, patient safety or a complaints process. What we're talking about there is actually real-time measurement of what it's like and what it feels like to be in the Irish healthcare system, either as a patient, a service user, a parent, or indeed someone who intermittently accesses health services. And indeed, those health services do need greater co-design of them, and that involves early engagement. And we've heard from Francis's excellent presentation earlier about how that can actually be meaningfully done, but also how you can learn from it. And also we're seeing, certainly internationally, the co-production of service delivery in terms of involvement of patients does lead to better quality delivery, and it leads to efficiencies within the service. So the evidence base around patient and public involvement is increasing, and it's increasingly winning hearts and minds. So it's quite positive to see that happening. I think what we're increasingly seeing is opportunities as well for patients to engage at a higher level in the Irish healthcare service, and that's to be welcomed. What we feel needs to be associated with those are the kinds of supports and training that would ensure sustainability of those approaches, so that it's not simply patients feeling quite isolated on committees, or indeed having a lack of connectivity to other advocates who are doing similar work. So this is really what we feel could be the centerpiece of patient centricity in Irish healthcare. But if we dig a little deeper, and certainly the areas that IPOSI has been both advocating for and indeed learning from ourselves in terms of what might make the ultimate difference of moving the Irish healthcare system from where it currently is to where patients are fully embedded. And really that's where you can have initiatives at the policy level. And certainly we've seen from the likes of the Canadian model and indeed the model in the Czechia, that both of these countries have a national patient involvement unit in the Department of Health. And part of their responsibility is to promote patient rights as part of the healthcare delivery in their countries. And indeed, what we would feel would add value to that unit would be a chief patient officer at the level at which you currently have chief medical and indeed nursing officers. And then you can bring that involvement level down to the level of the services, where you have a roadmap whereby those actually delivering services can actually point to what the end goal is, or what the ultimate goal of increasing the amount of involvement opportunities for patients and service users. And indeed, that roadmap needs to be properly resourced and supported with the types of mechanisms, skills for both patients and the professionals who are seeking to involve them more. And indeed, I think it's fair to say that there are an increasing amount of people in the health service who both recognize the value of patient involvement and are increasingly seeking this leadership to come from those at the top level in the health service and indeed at the health policy level to deliver this kind of vision for what we want to see and to co-design it with patient groups and their representatives. And indeed, the last part what we would be calling for would be to learn from the pockets of practices and innovation that is happening in the service side, and to put in the measures that can actually measure the experiences of both the providers of these opportunities and the patients and service users that are being asked to involve themselves more. So it's fair to say that in 2022, there's a number of opportunities for patient advocates that maybe didn't exist a couple of years ago. And these can be ranging from very high level in terms of the board of the HSE to quite technical level in terms of, for example, the Rare Disease Technology Review Committee, which looks at new orphan drugs and other technologies that the state is being asked to assess and to ultimately to make a decision on reimbursement. So these types of opportunities need greater connectivity between them to ensure the sustainability of the approaches that are being made for pre-existing patient communities, but also being more inclusive of maybe the seldom heard groups that we don't hear from an awful lot when we talk about PPI. So I won't dwell too much on this, but suffice to say that the efforts are ongoing to increase the amount of opportunities. And in IPOSI, we've tried to map where these opportunities currently are for a lot of the advocates. And we do have plans to measure ourselves what the experience of it has been like for a lot of the providers and the patients who are coming forward, because it's really important that we learn from current practices. And just to give an insight onto maybe some of the challenges around PPI and why maybe PPI isn't fully embedded to date in Ireland. So this is a Mentimeter slide from a survey we did with, we're involved with a master's program in digital health transformation, which the HSE co-sponsors with a number of universities. And it's where over 50 healthcare professionals are looking to improve their health services through digital transformation. And when we asked this particular cohort around what they believed were the main barriers or the challenges to PPI, you can see there that from their answers that the culture of the health system is still the number one. And certainly when we assessed and our patient members assessed a number of the projects that the students were proposing to deliver, it was very obvious that in fact, there is an individual responsibility in terms of professionals within the service, but there is a responsibility of the service itself at the national level to provide the kind of leadership that would help change the culture in which the current professionals work in and the current patients and service users and their families are seeking to get more involved in. So to finish, it's patient and public involvement has many P's, and this is a statement that we put together more recently in IPOSI about what we feel really encapsulates the main elements of a system that would not just recognize the importance and the impact that that patient and public involvement can make in the health system. And it's if I can just finish by reading it out, it's that public and patient involvement requires people with a passion and a purpose, with a place to meet and a payment for their involvement. It requires a willingness to pursue policy change with perseverance and persistence, while mindful of the need for practical application and in partnership with the health system. So I'll leave it there. Thanks, Tony.
Thanks very much, Derek. A very, very clear and thought-provoking presentation with a highly alliterative end, if you don't mind my saying so. So as Jan mentioned at the beginning, Helen Ruchford-Brennan was unable to take part today. And so we're both grateful and very fortunate to have Anne Lawler take her place. Anne is a founding member and chairperson of the 22q11 Ireland Support Group, an organization set up in 2007 that supports families affected by 22q deletion syndrome. Anne is a recipient of the 2017 Global Genes Rare Champion of Hope Award. Anne holds a master's in non-profit management from Dublin City University and a bachelor's in theology and psychology from All Hallows College. But it's her experience as a parent of a child and now an adult with 22q11 that has informed her ability to understand what other families might benefit from. Anne, you're very welcome, and the floor is yours.
Thank you very much, Tony, and good afternoon, everyone. And I'm delighted to be participating in this webinar about patient centricity for the future of healthcare in Ireland. It was a late call, so when Derek called me and asked, I thought about patient centricity, and I just jotted down a few words. Derek has mentioned many of them. I'm thinking virtual, digital transformation. I'm thinking genetics and genomics. I'm thinking precision medicine. I'm thinking integrated care. I'm thinking community-based care, and I'm thinking doing away with paternalism. So they were just a few initial thoughts I had around it. I don't have any slides, so I'm just going to talk to you a little bit about my own personal journey and how I came to the place I am now. So way back in 1998, when there was very little digital or internet or anything like that, way back then, my then 15-year-old daughter was diagnosed with 22q deletion syndrome. And I was told it was a rare disease. So this really baffled me for a lot of reasons. It explained all her symptoms, her disparate, mostly minor symptoms perhaps, but when they were all put together, considerable disability and a considerable challenge. But the one thing that really stood out to me was that none of these symptoms were rare. And also that her care was quite chaotic before the diagnosis, and it was still quite chaotic after the diagnosis because nobody knew anything about it. Certainly I didn't know anything about it. But all through that and long time after a diagnosis, nobody ever asked me what mattered to me as a parent. And her care was never patient-centric. Her care was all about her symptoms. And we saw several specialists. 22q11.2 deletion has somewhere about a possible 200 anomalies. I learned a lot about a layperson's, I would say, knowledge of genetics, and in particular deletions and duplications, and the fact that they're a significant cause of physical, intellectual, sensory disabilities, ASD, learning difficulties, all of that type of thing. So I went on then to set up the 22q support group, because I knew at this point that there was a lot of families. Ours is considered I'm glad Derek mentioned rare diseases, because I think there's a kind of erroneous thinking around rare diseases that they're all about cures and orphan drugs, and very often they're not. Quite a lot of my experience is around management, treatment, care coordination, all of that type of thing. So we went on to set up the support group, and I had 3 families at the time, and we've about 200 now. And I had a very, very clear vision, because of this personal lived experience, of what person-centered care looked like. And you can't treat a person in isolation. A person is in a family. The family is in a community. So there was, and there was nobody making links or connections to all of this. As I say, her symptoms were treated. There was no overall care, and I found myself in a position where I had to go outside the country to get the information that I craved, because nobody could tell me what the future held for her, and nobody could tell me, best treatments or management. So I started very slowly to make connections in Europe and in America, and I started to go into conferences. And that's where I gained all of the knowledge around 22q. And then I discovered there's a 22q duplication, and you can have distal deletions, and et cetera, and on top of that, that any of these blips can occur on any of the chromosomes. And learning disabilities and intellectual disability and mental health issues, they're all part and parcel of autism spectrum disorders, all part and parcel of it. But again, at the time, certainly at that time, there was nobody linking all these things together. So, you know, my experience of that, you know, and I've met many families now, and I've met many families, not just my own families, our own families here in Ireland, but in Europe and abroad and everywhere else. And our issues are all the same. We all want this timely access to care. We want some knowledge of the condition, and there was nobody. So in 2017, a pediatric consultant in Crumlin Hospital was given the task to set up a 22q clinic. And we have been working very closely with her over the past few years. We also, 22q Ireland now, we're a very small, voluntary, unfunded, wholly voluntary and unfunded organization, tiny. It was very difficult to get awareness raised. It still is, despite the fact that rare diseases are so common collectively. And we fundraised to host our own events, to bring our families together, because that's really, really important. The families have the lived experience and the knowledge. We know our own children best, and we live the lives. We live our lives with this condition on a daily basis. So we employed an independent mental health researcher to kind of pull all the literature. There was a lot of literature available about this condition, quite astounding, when I went looking for it. And we presented a business case to the HSE for a care coordinator. My instinct told me that this is something that needed care coordination. And we eventually got there, and we have a care coordinator in post since last November. And the phenomenal difference that has made, I really don't have the words to describe it, except to say it's not just patient-centric. It's patient-centric, it's family-centric, and it's also clinician-centric. This is a win-win for us. It's a win-win for the clinician. It's a win-win for the family. Now, I'm not trying to say that we have everything. We don't. We have a long, long way to go. We have a really long, there are so many specialities involved in this condition, that and every family is different. Every child is affected differently. So it's the clinical variability is enormous. So it's not an easy task. But I always say, if you take the most complex problem and you deal with it, everything else is kind of is more easily done than after that. So we have that now, and the clinician is finding it of enormous help to her to have the care coordinator. The families certainly are. I mean, I go to these clinics. This is what Derek was talking about, patients being more embedded. I go to these clinics. I have close relationship now with the care coordinator. Our clinician came with us to the international conference this year. It's just absolutely marvelous what's happening. We're embedding research into it because I gradually realized the importance of research, evidence-based research. And having said that, I could say a lot of things as a mother about lots of things, and people don't take that much heed of me, where they will if it's clinically based evidence. So I think that's needed. I think the patient voice, and I'm very happy to be here and to have my voice heard, but I think at this point it's not enough. We need to hear and we need to act upon what patients are saying. I mean, I ask our families, check in with them regularly. Are you happy with the way things are going? You know, what needs to be improved? All of that. It's a live, ongoing work in progress, and it always will be. We have a focus now on transition. There is, I feel for anybody who has a lifelong condition, and parents and families when their children get to 18, because basically it is a cliff face fall. There's lots of things to be looked at. We need adult clinicians. We have a lot of gaps in the service, which are now being revealed because of the care coordination post. I think it's a wonderful thing that's happened. It's been a long, hard, gritty road, but I think as a model of care and involving patients and families in it from the get-go and keeping them there all the way through, you know, we have to get away from this tokenistic kind of this tokenistic effort at involving patients. It's not enough. Derek alluded to a lot of it there, all the P's, the passion and the persistence and all of that. And I'm not alone in this. You know, I've met several parents, and I'm involved in several patient organizations, including the HSE Patient Forum. And it is a growing movement. I get frustrated maybe at the lack of progress around involving patients. But I do think that ultimately it is the way to go. I think our health service will be the better for it. I think our health will be the better for it. And I would think that's enough really for me to be saying at this point in time. I'm happy to take any questions or anything like that. So thank you for listening.
Thanks very much, Anne, for sharing your own direct experience, which I know everyone on the webinar will have been very interested to hear. I'd also like to now welcome back all the panel members as we move towards our question and answer session. And just a reminder that the Q&A function at the bottom of the screen is still open if anyone wishes to pose a question. I'm going to pose the first question to Derek, if I may, because one of your P's was the very specific question of payment. And there have been a few questions related to the issue of payment. How much should it be? How should it be organized? And what are the considerations? So Derek, would you care to take that one?
Sure. I think first and foremost, we would believe that anybody who chooses or accepts to get involved or wishes to get involved should be in the first instance offered an honorarium payment, because the commitment that's involved in a lot of the involvement opportunities is far significantly over and above what might maybe traditionally have been expected. So I suppose you would feel quite strongly about that whatever a commitment is involved, that the payment should be offered at least. There may be many reasons why a patient or a service user may not take it up. But they should be given the choice in the first instance. Now, there's a lot of work that is being done behind the scenes around how to get greater consistency about what might be an appropriate honorarium for different types of work. And a framework is being developed, we're told, and we've engaged with a process that was being designed and that was endorsed by the previous Minister for Health, that this framework for honorarium would be developed at the policy level, and that this could be implemented within the health service. Now, currently, the HSE has a policy of not remunerating patient advocates for involvement opportunities. And we would be very challenging of that, because we would see a lot of patient advocates actually becoming, as Anne has clearly articulated, that the frustration levels around this relatively small issue, because can lead to people just becoming disillusioned with the involvement process. And certainly that's something that we want to avoid at all costs, because as has been already indicated in the chat, the sheer number of people who are out there who can get involved to a much larger extent are actually quite rare. And we need to treat them almost as rare eggs, and make sure that they're well supported in the roles that are there for them. And honorarium are part of that solution. I wouldn't say that it's the only solution, but it's definitely part of it.
Thanks, Derek. Did you want to add anything to that, Anne?
Nothing really, Tony, except to echo what Derek has said. You know, it's different strokes for different folks. Some people, I mean, it was my own personal decision to immerse myself in this, but I saw the dire need. I suppose our approach in terms of PPI, we came at it from our own angle, because we knew our own needs. We knew not what needed to be done. And we did have to do it by ourselves. There's no mechanism whereby we can work together, really. It took a lot of knocking on doors and wearing out lots of shoes. Yeah. So
Thanks, Anne. I'd like to pose a question that's come in specifically to Francis, which is about what your advice would be, or what you think would be good advice to researchers who are new to patient involvement around a good practice that they might follow in engaging with patients and their families. You're muted at the moment, Francis.
Apologies, everybody. That's a very good question. I think at the very beginning, it's about really listening very carefully. Of course, a question was posed earlier about the hard to reach voices and the unheard voices. And of course, that's no more relevant than in stroke with people who can have communication difficulty. So we need to hear their voices as well. And our experience has been often they can come with a family member. I think try and make a plan, make it as easy as possible. Go to somebody, think about where everybody is, make it as easy as possible. We know that, you know, the Zoom and the Teams might not work for everybody. So I suppose think about the journey that you want to have together. For us, it was very much thinking about what the challenges were in people's experiences after stroke, and sitting down, first of all, putting out an invitation to everybody and bringing them together and thinking about what we were going to learn together in that conversation that we had, and really reflecting on hearing everybody's personal story, all the 20 people who came to meet us that day in RCSI. And of course, that could be an issue as well. It doesn't have to be, you know, in a particular venue. You could go to somewhere that is more suitable and meet people as well. So I suppose the logistical things in the background and listening very carefully. And then obviously that meaningful engagement that Anne has alluded to as well, that it's not tokenistic. So for us, it has been a learning process and we are still learning about it. And we're designing projects to answer the questions that we identified at the very beginning. So I think if you have a PPI manager in your organization, as part of PPI Ignite, they will have resources as well. Derek mentioned the reimbursement in RCSI, and in all the other universities, they've developed some guidelines for reimbursement as well. But at the end of the day, with all the guidelines and the principles, it's very much about meaningful engagement and listening very carefully to the conversation, and then making a plan together to work together on that journey. Because of course, and maybe I didn't touch on it in my presentation, but of course, when you come to the end of the research and you're communicating the findings, the next step is embedding this in practice. So, you know, I suppose bringing the research into practice for that patient-centric value add to the services to help with those transitions. So I think it's, you know, think carefully what the plan is, make time to plan for your PPI, schedule those meetings for PPI, make sure that they're not too long. We certainly found that maybe 45-minute an hour meeting was fine. Zoom can be very tiring as well. Think about all the practicalities of where to meet, how to meet. Think about the documentation that you're sharing as well. Don't have big, long documents. Give people plenty of time to read any documents in advance. And of course, reimbursement is part of this as well, and that recognition of the value of people's time in the process. So.
Thanks very much, Francis. David, if I could turn to you, one questioner has asked whether you have any examples where the where the outcomes that have led to policy changes were not initially considered by the clinicians, but were proposed by the patient representatives?
Oh, yeah. I mean, you can see there that how the patient's reported outcomes are very influential on our practice. I think sometimes there's an increasing recognition in our outcomes, particularly in the area of prostate cancer, and we only have to talk to them, our patient representatives. We've worked very closely with Men Against Cancer, a fantastic organization through the Irish Cancer Society, and then also the ARC cancer support groups. So in, I suppose, prostate cancer, it's a little different from some of the other diseases we've talking about, because we have a number of support groups that are already in existence, particularly around cancer, and have been in existence for a long time. And those support groups are very vocal, obviously, and they've been there to support patients, but really their voice hasn't been heard in clinical practice. But since we've been engaging with them now, and I think the Epcor study has highlighted patient outcomes in prostate cancer right across the country, the recognition of urinary outcomes, sexual function outcomes, and the psychological health of our patients has been only recognized. One of the initiatives, just to highlight, and what's really become very effective in clinical practice, is in the Mater Hospital where I work. One of our advanced nurse practitioners there, Catherine McGarvey, has led on a fantastic initiative called the Prosper Clinic. So the Prosper Clinic is a multidisciplinary service that all patients now with prostate cancer have access to. And what it involves is we have upfront psychological care for our patients. Patients get to meet in a small group with a psychologist who gives them essentially a list of the warning signs to look out for in terms of the diseases I mentioned, clinical anxiety, depression, and how they're feeling and how to cope with those feelings. And we've also introduced a physiotherapist who goes through pelvic floor exercises and allows them to manage their urinary complications. And then we speak to them really upfront about the sexual function outcomes they're going to have, and intimacy issues, and how to manage those with their partner. And we welcome partners to be involved in the Prosper group meetings as well. So we try to, at the same time, we're very conscious that Catherine's research has shown through a narrative study that she performed that a lot of patients will, upfront, you've got to be very careful you don't overload patients, particularly at a time when they're diagnosed with cancer. Like a lot of the illnesses we've discussed, like the 22q11, it's a lifelong disease they're coping with, whereas this is something which has suddenly arrived on the door of a maybe otherwise healthy person who's having to cope with a new diagnosis that's going to disrupt their life incredibly. And therefore, it can be very disruptive, and the psychological consequences that have affected patients, as I've said, we have lots of examples of very significant psychological effects. So thanks to the NCCP, as you know, there's a whole load of effort now made within psychological and psycho-oncology services. So really in the last 10 years, as you were saying, is there an example of where these PROMs and this new initiative in patient effect on patient symptoms has really impacted in our care? There's a huge initiative now around psycho-oncology services. Survivorship services are coming on board as well. And I think the information we're taking from the Epcor study is going to influence that, and the information that our patient support groups are giving us through the PROMs is going to influence the development of those survivorship clinics and those oncology services as well.
Thank you, David. There are quite a few questions coming at a common issue from different angles, and it's essentially about how you select and how you make sure that a public and patient representation is representative in that broad sense. And one question kind of encapsulates it, I guess. Health inequality and the social determinants of health is a major and growing issue. How can we make sure voices from the full spectrum of socio-economic backgrounds are involved? Could I come to you with that one, Derek?
Sure, and it's something that's obviously a real challenge for a lot of those who are involved in PPI in terms of the inclusivity of approaches. And certainly speaking as a male voice, I often find that there's actually a lack of male voices in PPI, and that's not to say that we need more men, but the simple fact of the matter is that it is quite a narrow I think, snapshot of the general patient population that currently are able to get involved in these increasingly large commitments that are required to get involved. So the kind of approaches that would ensure greater representation, there's lots of good practice out there that is happening in areas maybe outside of health, and such as social care, and indeed some real innovative approaches in terms of mental health, the local recovery groups. There's lots of practices there that can be learned from in other areas to broaden the scope by which the population that you're hoping to recruit from. So yeah, so it's something also that needs to be embedded probably at the very top in institutes and in agencies, and really in terms of the principles of inclusivity, of diversity, really need to be lived and breathed in terms of the operations of different agencies and their work processes. So there's lots of good work and lots of I think templates out there that can be used and transformed into individual services, but you need that combination of both a principle by which you abide by, and then tools and resources to be able to actually reach out to those groups that maybe you haven't heard from to date in your own efforts to involve.
Thanks. Anybody else on the panel like to add their thoughts on that question?
I think maybe giving people the confidence as well to have their voice and to contribute their voice. That's something we've experienced with our iPass PPI group. Some of the members recently going forward to do training in World Cafe methods so that they can be co-researchers in our co-design activities, and really, you know, creating a safe space and that encouragement to say, you know, that everybody's voice matters, and we'll try and do our best and look at solutions to ensure that we get to the voices that we may not be hearing.
Just to add there, Tony, so that a recent study there by the Antoinette Perry's group in UCD, the Improver study, went online, and obviously through social media would have been able to access the general population on Facebook, and 98%, I think, if I'm not mistaken, of patients who responded were white Irish male homosexuals or heterosexuals in terms of their responses. So in terms of the diversity that you need when you put out a campaign, obviously in the general population, I think a much greater effort has to be made in terms of reaching out to more marginalized people, different ethnic backgrounds, different sexual preferences, and so on, and obviously transgender as well. So there's, I think, greater, obviously, efforts need to be made to engage these minorities in our research as well.
I would think too, Tony, that a lot of it is down to, you know, the public and patient involvement becoming the norm. You know, it's not the exception. It becomes the normal way of doing things or being, like, and I hear what Francis said there about confidence, because it took me a long time, even though I had a very clear vision of what was needed and where we needed to go. It took a long time for me to gain that confidence, and perhaps there's room for patient leadership programs, if Derek would know a little bit about those too, and that type of thing, and giving people the opportunity. But underneath it all, it's about treating. We're all human, you know. We are all human. It's about treating each other as equals. And I would think it's important not to lose sight of those type of things.
Thanks, Anne. There are a number of questions, Anne, that are seeking your perspective on what needs to be done to involve patients in the development of medicines and health services, and to make sure that such involvement is a positive experience. I mean, you used the term before, I think, in your own remarks about the danger of tokenism. So perhaps that's what sparked the question.
Yeah, I think we're as patients and public, we're on a certain uneven footing And to level that playing field, I'd go back to the point that Derek made earlier, because I'm also interested in this, in what's happening in Canada, the Patient and Family Advisory Council. You know, we need to be taken seriously, and our views need to be taken seriously. And to do that, we have to be at that top table, I think, eventually. Hopefully we're inching our way, because that's what it feels like. It's an inching our way there. But Derek might add to that also.
Would you care to, Derek?
Sure. I think that overall, ensuring that it's a positive experience requires, I think, first of all, measures of that experience. You need to actually demonstrate that the experience has led to an influence or an impact. So very often, even when opportunities are created for patients or the public, there's no real kind of well, what is this being created with a view to impact on, and what does influence or impact look like to that either individual or patient group. So by putting in place the kind of measures, be they qualitative or quantitative, to measure what the experience was like, both from maybe the patient and indeed the provider side, you're then able to actually prove the case to others, and maybe those who are kind of looking with a little bit of trepidation about the commitment that's involved, certainly for the higher level involvement opportunities, about what the experience of that might be like. So the positivity can then actually flow from those stories of involvement. So that's the way I would see the kind of culture change that's probably necessary. Yes, the supports and the infrastructure and the involvement of patient groups is all really important, but if we need to capture that story of what it's like to be involved, particularly at those higher levels.
Thanks so much. Just, is there any final thought you might have on that particular subject, David or Francis, just before I bring the seminar to a close? Very good. Listen, thanks very much to our participants today. Our panel, all members of the panel brought us really good and insightful presentations, and I think the questions and answer session has been really useful. As Jan mentioned at the opener, this is the third and final in this year's series on the future of value-based healthcare in Ireland. And every participant is going to be sent a feedback form. We'd be very grateful if you would do that. I'd like to thank Jan and everyone at the Healthcare Outcomes Research Centre in the RCSI for putting this series together. I'd like to thank all of you for joining us today. And I'd also like to acknowledge Janssen and Novartis for sponsoring the series. Again, my thanks to all of today's presenters and all those who've taken part in the whole series. And I hope that you found your participation both useful and worthwhile. And with that, I'll bring today's webinar to a close. Thank you very much.